Endoscopic endonasal approach for craniopharyngioma, the new gold standard.
بنرحب بالاستاذ الدكتور محمود صديق نائب رئيس جامعه الازهر للدراسات العليا والبحوث، والاستاذه الدكتوره نيره عميده كليه الطب سابقا، واعضاء مجلس الشعب دكتوره
استاذه شاديه خضير اللي نورتنا النهارده عضو مجلس النواب، استاذ دكتور ابراهيم عويس عضو مجلس النواب. انا دقيقه واحده بس. انا الدكتور احمد رزق مدير مستشفى السلام التخصصي. يعني مش قادر اقول لحضراتكم قد ايه انا سعيد بالمؤتمر الجميل ده. كان احد احلامي ان انا اكون ولو ذره صغيره في جامعات مصر، ان انا اقدر اعمل حاجه من مستشفى السلام تقدم خدمه عظيمه واساتذه كبار. الحقيقه احنا عملنا المؤتمر ده لقسم التجميل، عملنا المؤتمر ده لقسم العظام، وبنكرره لتاني مره لقسم المخ والاعصاب. فالحقيقه انا فخور بمستشفية السلام ان هي قدرت تتشرف بالكوكبه دي كلها. شكرا.
شكرا. Professor Albert.
Hello, good morning everyone. Can you see my screen? And can you hear me? I don't have any feedback. Can you hear me?
We can see you quite clear and we can hear you clear. Please go on.
Okay, thank you very much. Thank you very much. I'm very happy to be with you for this meeting. I'm coming from Paris, from the neurosurgical department of the Rothschild Foundation Hospital. And I'm mostly in charge with the endoscopic skull base and vascular neurosurgery. So as Professor Chandrasekhar said before, it's a very complicated issue, craniopharyngiomas. So having a multidisciplinary team, it's essential for this kind of tumor and of course for other types of tumors in the skull base. So craniopharyngioma was already coined by Cushing in the 30s as one of the most baffling problems confronting the neurosurgeon. And that's especially the case because even if it's a benign tumor, it's a locally invasive tumor which affects the pituitary, the hypothalamus, the visual and vascular structures. It has quite an unpredictable biological behavior, and it's a very rare tumor which makes very difficult to accumulate experience, and so very large series are quite rare. I'll speak briefly about the two different types of craniopharyngioma. Professor Chandrasekhar already treated this subject. So you have adenomatous tumors, which are predominantly in children, which are mostly mixed, solid and cystic. Very important, they have infiltrative irregular borders and they present the beta-catenin gene mutation. The papillary variant is more frequent in adults. It may be solid or mixed, solid and cystic, and has better defined borders. So a complete resection, it's easier in this type of tumor. And it presents a BRAF gene mutation. There are a lot of controversies about the management of craniopharyngoma. One of the most recent is which is the best way to treat them. It is better to go endoscopic or conventional by transcranial approaches. An older discussion was radical surgery versus partial surgery and radiotherapy. Should we sacrifice the pituitary function for cure? And of course, the role of complementary treatments. What is sure, it's a gross total resection offers you a highest rate of progression-free survival. I think planned subtotal resection, it's best if you want to preserve hypothalamic and pituitary function, and this is especially true in children where the adenomatous version is prevalent. Recent studies have showed that endoscopy gives better ophthalmological results and higher rates of hypothalamic preservation. The controversies about the best surgical treatment is related to the disadvantages of the open skull base approaches. They imply a significant brain retraction working through small surgical windows sometimes manipulation of the optic apparatus, and especially a very poor visualization of the retrochiasmatic area. I think this is why we have so many approaches which have been offered for craniopharyngiomas, the pterional, the eyebrows, the subfrontal, unilateral or bilateral, the posterior petrosal approach, the transventricular approaches. I think what's most important when dealing with craniopharyngioma is understanding where the craniopharyngioma started. And I think the advantage for endoscopic approaches start from the point that the craniopharyngioma is basically a retrochiasmatic tumor. It may become through its development a subchiasmatic or a prechiasmatic tumor, but the origin is always retrochiasmatic. And the problem is that most of the conventional surgical approaches give you a very poor view of this area, with the exception maybe of the posterior petrosal approach. The other approaches don't give you a direct view of this area. This problem was already identified by Kassam, the group of Pittsburgh, in 2008, and they offered this first classification of craniopharyngioma. Professor Chandrasekhar already spoke about it. But I think one of the most important papers about understanding the origin of craniopharyngioma was this paper from a Madrid group who identified 3 types of syndrome concerning the infiltration of the suprasellar area: a pituitary syndrome, an infundibular tuberal syndrome, and a hypothalamic syndrome. It's very important to identify clinically these syndromes in your patient because they can tell you a lot about what you can and what you cannot remove. Usually when hypothalamic syndrome is present, this indicates quite an aggressive invasive tumor for the hypothalamus, and you already know that you leave some tumor behind. And in this article, they showed that the craniopharyngioma can develop anywhere on the long of the axis of the pituitary stalk. They developed a new classification which divides craniopharyngioma in 5 categories: sellar suprasellar, pseudo intraventricular, secondary intraventricular, not strictly intraventricular, and strictly intraventricular. It looked like not very practical classification, but we'll see that it gives some precise criteria to separate the lesions and to understand where they come from. One of the criteria is a mammillary body angle, which looks in the deformation of the angle between the plane of the aqueduct sylvius and the plane of the mammillary bodies. If the tumor is sellar suprasellar, this angle will tend to be obtuse. If the tumor originates in the hypothalamus or superior to the floor of the cell ventricle, it will be more acute. So the 7 criteria for this classification are the cell ventricle occupation, the pituitary stalk distortion, the level of the hypothalamus, the chiasmatic system occupation, the mammillary body angle, the type of chiasm distortion, and the tumor shape. And so it gives you 5 types, and using these 7 criteria, you can predict the topography of the craniopharyngioma in almost 90% of cases. So these are the 5 types, and I give you the reference in order to see this article, which seems to me very important for the understanding of the craniopharyngiomas. So is the endoscopic endonasal approach a new gold standard? It certainly has quite clear advantages because it gives a direct corridor to suprasellar area, a superior close-up view of the relevant anatomy. It gives you better chance of stalk preservation, enlarged working angles in the suprasellar area, and a better appreciation of the limits and a better visualization of the subventricle. Certainly, there are disadvantages, and mainly the CSF leak. I think it's the main obstacle for the wide adoption of the endoscopic approach, and of course, the rhinologic complication. So, direct corridor to the suprasellar area. Actually, it's very intuitive. If you use the 2-point method described by Spetzler for cavernoma, it's very logic to choose the endoscopic endonasal approach. One obstacle may be the pituitary chiasm corridor, which is very small in this case, But actually, while you are decompressing the tumor first, you may access very well and enlarge this corridor without problems. I think the endoscopic endonasal approach is the only approach which can give you this kind of view. You see a panoramic view going from the anterior communicating complex to the basilar bifurcation, also the preservation of the stalk, and a superior close-up view of the relevant anatomy. As we have seen in the neuroanatomy topic earlier, the vascularization of the chiasm sometimes resides in very small vessels like the superior hypophyseal arteries, and having the possibility to dissect very close to these vessels gives you better ophthalmological results. And also a better possibility, like in this case, of preservation of the pituitary. And you see an image that you can never see in craniotomy of the mammillary bodies, of the bifurcation, the carotid, and all the perforating arteries. What are the limits for the endoscopic approach? I think the limits are the large subfrontal and lateral extensions, and maybe not always the purely intraventricular craniopharyngiomas. This is an example of a case which has not a very large cystic expansion, but there is engulfment of the internal carotid artery on the left side. There is a solid component superior and the cystic component inferior. So in this kind of cases, you have very stuck communicating and anterior choroidal artery to the tumor. So pterional approach works best, at least in my hands. Disadvantages, so I talked about it. So CSF leak remains a problem, and you should aim for diminishing as much as possible this complication. Anosmia and chronic rhinitis also are significant problems. What is my take-home message? So I think the endoscopic endonasal approach is not yet the new gold standard, but it may become one soon. You still need to tailor your treatment to the tumor, as Professor Chandrasekhar said. And I think the equivalence of gross total resection and subtotal resection plus radiotherapy should be revisited in the endoscopic area. These are data which go back to the microscopic time. So we should probably look into it to see if this is still true. Master different closure techniques is still a must. So I hope I still have some time to show you rapidly an example. So this is a 27-year-old male without past medical history, which came for memory difficulties and visual troubles. He had a large craniopharyngioma, suprasellar and intraventricular, which corresponds in the classification I spoke about to the secondary intraventricular craniopharyngoma. I'll speed through the approach. It's a classical approach with a nasoseptal flap, a large opening of the sella and of the tuberculum cellae, opening above and below the intercavernous sinus, which is coagulated and cut. And this is the initial exposure of the tumor. You can see that it's a retroinfundibular tumor. The pituitary stalk is here. So first we dissect the limits of the tumor with the vessels. We decompress the suprasellar part of the tumor and gently separate it from the superior hypophyseal arteries on the right side. It's very important in this kind of tumor where the corridor is quite small to debulk it progressively. And this allows you to remove the suprasellar part and progressively make the superior part of the tumor go in the working area. Still a lot of tumor debulking. And you see now the intraventricular part comes into view, and it may be dissected and gently teased out of the ventricle. And now we are in the third ventricle. This is the most superior part of the tumor, which is removed. And this is the view inside the third ventricle. The pituitary stalk is preserved. A small residue of tumor. And now you see perfectly the third ventricle, the pituitary stalk, the lower part of the optic chiasm. So preserving the pituitary stalk is not a guarantee for function. This patient presented complete pituitary insufficiency postoperatively, but he had a very good postoperative course. The closure was done with the nasoseptal flap classically. He did a very good visual recovery, and his memory difficulties improved after cognitive rehabilitation. The MRI showed a complete tumor resection. So thank you very much. I would like to thank the organizers and especially Dr. Sameh for everything, and I'm ready for your questions.
Any question? Thank you. Thank you, Dr. Sorin.
You're welcome.
Now we'll move. Now we will move to Professor Albert Sofianov, Chief of Neurosurgery Department, Tayaman